So I just want to start off. Thank you for the introduction. I have no conflicts of interest to declare. So let's go back to the onset of COVID in 2020. It's interesting because many of my colleagues and we predicted that we would see a lot of these post-viral syndromes. And we expected these patients to have a combination of symptoms. They would have fatigue, pain, sleep disturbance, brain fog, and unexplained symptoms. And that their symptoms would include gut symptoms, autonomic symptoms like postural orthostatic tachycardia syndrome, and neurocognitive symptoms. Interestingly, if you look at the symptoms that have been described with these conditions, not just long COVID, but chronic fatigue syndrome, fibromyalgia, over 200 different symptoms have been described, which makes it very confusing when you're trying to get the big picture. But if you remember these 5 categories, fatigue, pain, brain fog, sleep disturbance, and unexplained symptoms, you'll capture all of those more than 200 symptoms. So it was comical to us when we saw stuff in the news that it stumps experts. Well, they were asking the wrong experts because many of us had already predicted this. And like a lot in medicine, we have to give it a new name. So they initially called it long haulers. And they said many of the long haulers never had laboratory confirmation of COVID, which adds to some healthcare professional skepticism and psychological basis for symptoms. The authors wanted to reinforce the idea that these mystery diagnoses are real and they're not just in patients' heads. Because unfortunately, patients with chronic fatigue syndrome and fibromyalgia have a bad history of medical gaslighting, and for a lot of these post-viral syndromes as well. And so I thought, and my colleagues thought, that given the legitimacy of COVID and long COVID, that we would not see nearly as much gaslighting. Unfortunately, that wasn't the case. So let's start off with how many of us kind of thought about this. And this is a paper dating back a while, and it looks at post-infective and chronic fatigue syndrome precipitated by viral and non-viral pathogens. And this was a study done in Australia. Basically, they looked at patients that came to the infectious disease clinic, and they found that 11% had chronic fatigue syndrome at 6 months, and that this was consistent across infection. And so they said, it doesn't matter what the pathogen is, this is just a host response. And you'll see that this number around 10% keeps coming up, and this is exactly what we predicted 3 years ago. But medicine likes to give new names, so there is actually a disease called post-Ebola virus disease syndrome. And if you see over here, you have pain, fatigue, sleep disturbance, neurocognitive symptoms, and unexplained symptoms. So this is simply chronic fatigue syndrome triggered by Ebola virus. We have post-treatment Lyme syndrome. And all this happens in about 10% of patients who have true Lyme, and they go on to develop chronic fatigue syndrome or fibromyalgia. And so about 10%. So let's come back to the medical gaslighting and my disappointment in the fact that we would see less of it. So already we see here a contested illness is born. So rather than accepting long COVID as a post-viral syndrome, you had a number of physicians who are saying, this is not real. It's in patients' head. If you're interested in reading about medical gaslighting, I was interviewed for an article by Dr. Anthony Fung, an emergency doctor, on the unfortunate ongoing medical gaslighting and how it's harming patients with chronic pain and chronic fatigue. So if we look at the post-COVID condition, we're going to talk about what post-COVID means because nobody seems to agree. But you'll see that pain and fatigue are among the highest top 5 symptoms. And here it says many patients recover from COVID, but some exhibit persistent or new symptoms. And these have been variously referred to as long haul COVID, which has fallen out of favor, long COVID, which is still being used, and post-acute sequelae of COVID, which has been proposed, but is a mouthful. So I'm not sure if this one is going to persist, but also I want to talk about some distinctions between how different physicians use these terms, because often you'll see there seems to be contradictory information about long COVID. And part of that comes from the fact that long COVID is being defined differently. I personally use the same naming convention as the Mayo Clinic in Rochester. And they say that there are, if we look at post-acute sequelae of COVID, so they say that post-acute sequelae of COVID is an umbrella term, it's a catch-all. It's all of the things that can happen after COVID, after you recover from the acute illness. And they break it down into three groups. They identify those with tissue damage, lung scarring, myocarditis, loss of taste or smell. And these are easy for physicians to deal with because they have obvious objective clinical findings. Then we have the ones with no identifiable tissue damage, the post-viral syndrome. And these are the ones that have the big five symptoms: pain, fatigue, sleep disturbance, brain fog, and unexplained symptoms. And the group in the Mayo Clinic has suggested that these patients are part of the family of conditions called central sensitivity syndromes. They almost went, but not quite as far, to say that many of them go on to develop chronic fatigue syndrome. They also identified that pain was a significant symptom. What's interesting is that when they did this study, they excluded patients with pre-existing central sensitivity syndrome. So they excluded you if you had IBS, fibromyalgia, chronic fatigue syndrome. And one of the other things that my colleagues and I predicted at the onset was that anybody who has PTSD, IBS, migraines, all of those central sensitivity syndromes would be more likely to develop what's now called long COVID, or a post-viral syndrome after contracting COVID. And we also predicted patients with pre-existing chronic fatigue syndrome and fibromyalgia would have an exacerbation of their symptoms, some of which may not return to baseline. And that's turning out to be true, although it hasn't been captured in the literature yet. So these are the patients that are identified as long COVID by the Mayo Clinic, and that's how I use the term. So post-acute COVID, three groups. Do you have tissue damage? Do you have no identifiable tissue damage and normal testing? So these are the long COVID. And the third group are those patients who develop psychiatric or psychological symptoms after COVID, so depression, anxiety, and PTSD. So we're going to focus on those who recover from the acute illness, go on to have fatigue, sleep disturbance, brain fog, and unexplained symptoms. So this will be similar to young adults who get mono, and some of them recover within a year, and some of them never go on to develop, or most of them never go on to develop full-blown fibromyalgia or chronic fatigue syndrome, myalgic encephalomyelitis. So that reminds us that post-viral syndrome is not the same as chronic fatigue syndrome or fibromyalgia. A lot of patients will have milder symptoms and not fulfill diagnostic criteria. The other hypothesis that my colleagues and I generated is that those who have the five symptoms, the fatigue, sleep disturbance, brain fog, et cetera, who do not fulfill criteria for chronic fatigue syndrome or fibromyalgia are the ones most likely to recover. So I'll have to see if the literature pans that out in the long term, but certainly in my practice, that's what I'm seeing. So over here, you could see some of the early papers estimated that 10% of patients may develop chronic fatigue syndrome, very close to the 11%. but it may be too early to establish a direct causal relationship. Well, that's kind of fallen to the wayside. Here it says, although this is another paper, although 50% patients, they have lingering symptoms for 3 months, we assume that only 10% will be left with chronic fatigue syndrome. So another group of researchers, clinicians who are identifying this as. And this makes a big difference because we have an opportunity. Most patients, especially in Western society, when they develop chronic fatigue syndrome, fibromyalgia, are told to push themselves, to fight their symptoms, to exercise through symptoms. And we now know that that just makes patients worse. And so those who have post-exertional malaise and worsening of symptoms, the classic pathognomonic feature of myalgic encephalomyelitis / chronic fatigue syndrome, that those patients should be told to rest. And I call it aggressive rest therapy, the 3 Ds. So aggressive rest therapy is delete anything you don't have to do, delay anything that doesn't have to be done right away, and delegate anything that somebody else can do. However, again, this was missed. And what happened was that occupational therapists and physiotherapists were recommending exercise in patients with long COVID. And so here is an article, it's an editorial, it says humility and acceptance, and how they forgot about chronic fatigue syndrome and how they were making patients worse after the start of the pandemic by telling them to exercise through symptoms. Now what they're saying is stop, rest, and pace. And just like post-Ebola virus syndrome and all these other post-Lyme syndrome, we've got to invent new names for things. So here's a group who wants to talk about fibro-COVID. So if you develop fibromyalgia after COVID, rather than just saying it's fibromyalgia precipitated by a viral infection, which is commonly known, and this is simply fibromyalgia precipitated by a virus, this group is suggesting that the term fibro-COVID, and they've identified that 30% of long COVID patients fulfill criteria for chronic fatigue syndrome. So with chronic fatigue syndrome and fibromyalgia, we usually see a precipitant. And that precipitant is some form of stressor. It's a physical stressor, a psychological stressor, or an infectious stressor. And so over here, you can see that the virus or long COVID is simply one of the known precipitants for these conditions. And you know these conditions. These are the central sensitivity syndromes. And the ones that we deal with at BC Women's are fibromyalgia, chronic fatigue syndrome, also called ME, and chronic Lyme disease, all central sensitivity syndromes. And so here are some of the others. But these central sensitivity syndromes don't occur in isolation, they cluster. And so here you can see that patients with fibromyalgia, 40% of them will have IBS, almost 25% will have TMJ, then headaches, and over 55% will have chronic fatigue syndrome. I believe this is an underestimate. In having seen close to 7,000 patients with these conditions, I can tell you it's closer to 75%. So these central sensitivity syndromes, and here's a long list. On average, the patients that I see, which is obviously a skewed population because it's a referral population, have 5 to 6. The range is 1 to 14. I have only seen one a handful of times. So just pure fibromyalgia, pure chronic fatigue syndrome without any other central sensitivity syndromes is not common. And so when you're making the diagnosis, you know it's a slam dunk when somebody has fatigue, post-exertional malaise, pain, brain fog, and a history of migraines, IBS, and PTSD. That's pretty much a slam dunk. So I just wanted to talk about the naming conventions and how artificial they are. because over here are the 2003 Canadian Clinical Working Case definition for chronic fatigue syndrome, ME. And you'll see here that POTS is part of the diagnostic criteria. Well, POTS is another central sensitivity syndrome, and IBS is part of the diagnostic criteria. So you use another diagnosis to make a diagnosis. So is this an association, or is this simply, or rather than an actual symptom of chronic fatigue syndrome? And here you can see urinary frequency and bladder dysfunction. Is this just mild interstitial cystitis? And over here, you'll see new sensitivities to foods, medications, and chemicals. Is this not just a milder or a full version of environmental sensitivities, multiple chemical sensitivity syndrome? And so it's not surprising that in my hands, 75% of patients fulfill criteria for fibromyalgia when they have chronic fatigue syndrome, because if you look at the overlap, fatigue, sleep disturbance, pain, which can be widespread, brain fog, IBS, and headaches. What do you need to make a diagnosis of fibromyalgia? Widespread pain, fatigue, unrefreshing sleep, abdominal symptoms, and headaches. So I'm not 100% sure that these are separate conditions or how they separate. Are we seeing final common pathway from multiple different conditions? But remember that these are syndromes. These are just a handful of guys and gals in a room saying, let's group these symptoms together. If we look at myofascial pain syndrome, what do you have? Myalgia, fatigue, sleep disturbance, brain fog, unexplained dizziness, autonomic symptoms. That's the same as the big five. And so the only difference here is that the pain is localized and associated with trigger points. So is this just a form of localized fibromyalgia? To make things even more complicated, about 75% of the patients that I see with fibromyalgia have myofascial pain syndrome. So let's look at the pathophysiology of a couple of these things. And you're starting to get the picture that long COVID isn't anything different and isn't something that you already don't know. So the bottom line of this presentation at the end is, you got this. This is just what you already know. COVID is just a precipitant of these conditions. So you'll remember that mitochondria, not hypochondria, is the cause of chronic fatigue syndrome. And the mitochondria is a cell's powerhouse. And some of you may remember a name for chronic fatigue syndrome that didn't pan out: systemic exertion intolerance disease. Part of the reason that they wanted to call it that was the exertion intolerance. And these are the studies that helped the Institute of Medicine make that suggestion. So let's remind you about VO2 max. So here's oxygen consumption, and here's how hard you work out. So the harder you work out, the more oxygen you use, but then you reach a peak where you can't use more oxygen. And so VO2 max is the point where you transition from aerobic to anaerobic metabolism. And your VO2 max will vary according to how conditioned you are. So a couch potato might have a VO2 max over here. An Olympic athlete might have a VO2 max up here. This is one of the studies by Stacy Stevens and her group. I'll take you through this slowly. But what this group did was they looked at 2 days in a row rather than just one day, which was brilliant. So if we look at day one, these are the control group, and they used couch potatoes. So if we had Olympic athletes, you could see the bars would be higher. And basically what they looked at was, what's your VO2 max and how hard you work out? So over here, you can see that a control group, they worked out harder and they used more oxygen. Not surprising compared to the chronic fatigue. If you can't exercise because of chronic fatigue, you're going to be deconditioned. That's why a lot of the early studies blamed chronic fatigue syndrome on deconditioning. But what Stacy Stevens did and her colleagues did was they looked at day two. And you can see that there was no significant change between the day 1 and day 2 for the control group, but the chronic fatigue group had a more than 50% decrease in VO2 max. So it means that they went into anaerobic metabolism at a much lower activity level and at a much lower heart rate. And so this is the pathognomonic reason for post-exertional malaise, is an inability to use oxygen when you overexert yourself. So let's look at the pain in these conditions, because I don't need to go over this. You guys know that pain is processed at the spinal cord, at the brainstem, and in the brain, and that you can have a problem anywhere along this pathway. That chronic pain is characterized by sensitization and amplification. So not only is there a problem on the way up, but the descending pathway, which kind of says, okay, got the message, turn down the pain, is not working properly. So basically what you have is a shift in the pain curve. So if we look over here, we have pain sensation. So this is nothing, ouch, 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 and ouch, ouch, ouch. And this is how much I'm hurting you. And what they tend to do in studies is they squeeze your hand with a vice. And so over here, it's innocuous. This should just be touch. And at this point, it's starting to hurt. It's starting to cause tissue damage. And you can see that the pain curve is a little bit like an S curve. What happens with chronic pain or injury is that it moves in this direction. There's a left shift. So something that over here should just be slightly noxious over here, in the person with the left shifted curve, hurts this much. So it should only hurt this much, but it hurts this much because the curve is shifted. And we call this hyperalgesia. And over here, pain in stuff that's innocuous, so where touch becomes a sensation of pain, we call allodynia. So before we had fMRI studies, they would just say, patients just exaggerate, they complain, they're wusses. But now we have magnetic resonance imaging. So when I go to court and they tell me, doctor, isn't pain subjective? And I say, no, we actually have objective testing. It's just not widely available. And so this is basically the same curve, but with much fewer data points. So the squares are the controls and the triangle is fibromyalgia. Again, pain intensity, ouch, 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 ouch. And over here, they're actually telling you how much they're squeezing the vice, kilogram per centimeter squared. So you can see in a subject that is a control, I squeeze a little bit, it hurts a little bit. In fibromyalgia, it hurts this much. In fact, it hurts as if I was squeezing this much. So objective evidence of increased pain. So how does this fit together with the virus? And what's causing the problem? In the old days, I used to say, I have no idea how all of these abnormalities are connected together. I just know that they exist. But the research in the last 10 years has really come up with a lot of interesting data. And we're starting to look for what I call the first domino. Because before I knew all of these things were happening, but I didn't know how they were connected. Because if we fix something over here, it's not likely to have a major impact. If we could fix something up here, it's likely to have a major impact. And it turns out that it has to do with the glial cells, the unsung heroes of the brain. And the glial cells make up about 3/4 of the brain cell, and yet most patients have never heard of them. And so here we have the microglia, and the microglia are kind of like the macrophages. They're the immune cells of the brain, and they can act locally. And here you can see it's secreting and having a local effect on a neuron, but they also have foot processes that can secrete stuff into the peripheral circulation. So they are part of the immune brain connection with the rest of the body. And we know that glial cells are, quote, activated. And activated is just another word for unhappy. So we have unhappy activated glial cells that are producing these inflammatory cytokines. Here's the evidence for both systemic and neuroinflammation in fibromyalgia. Again, the glial cells are unhappy and are producing inflammatory cytokines. And that's why we use naltrexone, because naltrexone, I say, puts the glee back in the glial cells, makes them happy again. And you can see that all of these are part of the inflammatory cytokines, but that on average, there's about a 15 to 20% reduction in inflammatory cytokines and symptoms. And these are overall symptoms. And that kind of fits with the hypothesis that this is higher up the domino. It's one of the first dominoes. And so this is one of the many papers that have come out lately about the neuroinflammatory model can explain symptom flare-ups in these patients. So basically you have your initial trigger like COVID, and you end up with glial cell activation and neuroinflammation. But in a subset of patients, when you exceed a certain threshold of that stress response, they get stuck in a vicious cycle that can't turn off. And so this is one of the main models right now for the onset of central sensitivity syndrome, specifically chronic fatigue syndrome, fibromyalgia. And so basically, we have our activated, unhappy glial cells that are producing inflammatory cytokines that are also releasing them to the general vascular system and having the neuroimmune crosstalk that we talked about earlier. And we know that this is highly connected to the microbiome gut-brain axis, that the vagus nerve also releases neuroactive molecules, and these are the happy molecules for the gut. And the immune cells are in the gut are activated by those inflammatory cytokines. And so these are the unhappy molecules where you get the leaky gut and the dysbiosis. The other thing that I'm not going to talk about is that as part of this process with the inflammatory cytokines is you get an imbalance between the autonomic nervous system. So there's an overactivity of the sympathetic nervous system and an underactivity of the parasympathetic. And of course, the parasympathetic is the vagus nerve. So fewer happy molecules that help with the gut. Remember the vagus nerve, parasympathetic, rest, digest, and more inflammatory cytokines activating the immune cells in the gut, which is why these patients have so many gut symptoms. So basically, this neuroimmune dysfunction starts with glial cell activation, cytokine production, immune activation, dysbiosis, autonomic nervous system imbalance, and pain amplification. And a lot of these have an impact on the mitochondria, especially the cytokine production, which is where you get your fatigue. So the bottom line is that you already know this, that long COVID or COVID causes three things. It either causes an aggravation of pre-existing pain, you got this, or it precipitates chronic fatigue syndrome and fibromyalgia, you got this, or it may make other central sensitivity syndromes appear, like irritable bowel syndrome, interstitial cystitis, PTSD. You got this. So the bottom line for my talk is there's really no need for it because you got this. You already knew all of this stuff. Long COVID is simply a precipitant of these pre-existing conditions or new conditions that we already know about. Just for fun, this is my dog and her puppy. And let's go to questions. I want to make sure I left enough time for questions.
Fantastic. Thank you so much. And appreciate the puppy photo. All right, well, we got a couple questions in the Q&A already. And so anybody else, if you have questions, please enter them there, and then I will ask them as they come in. All right, so I actually, I have a question first. So you started out talking about medical gaslighting and how this is something that happens a lot for folks who have chronic fatigue syndrome and other central sensitization syndromes. I'm wondering, how do we combat that medical gaslighting? Are there strategies that you recommend to patients?
Well, it's it's really about physician education, right? That's physicians have a short memory. They forget as a profession that multiple sclerosis used to be a psychological condition until the MRI was invented. And so it's what I call the Sherlock Holmes fallacy. And some of you will know that Sherlock, the writer for Sherlock Holmes, was actually a physician. And the idea was that once you rule out every possible cause, whatever is left over is the cause. That's wrong, because it makes a fatal flaw assumption that you know all the possibilities at the outset. And basically, with MS, with phantom limb pain, with post-herpetic neuralgia, where we could find nothing wrong. So when physicians see patients with symptoms, there's a difference between we can't find a cause for your symptoms and there's nothing wrong. And physicians often don't make that distinction in the language. So for instance, when I see patients and I order a CT scan, I pre-frame it by how we're going to interpret it. I say, well, your symptoms might be related to all your central sensitivity syndromes. Let's make sure there's nothing else going on. And so if the test comes back negative, that'll tell us that it's most likely your fibromyalgia, or most likely your IBS, or most likely your irritable larynx syndrome. And when the tests come back, we've already pre-framed it. Rather than saying I have a sore throat, I went to see ENT, there is nothing wrong. Well, of course there's something wrong. The patient knows there's something wrong. And to try and tell them that they don't when they know, it just ruins your doctor-patient relationship.
Thank you. That's a great answer. All right. The questions are coming in fast here. All right. I will just start with the top here. Someone asks, what do you think of the new hypnotic Davigo for sleep?
Whenever there's a new medication, the only downside to it is we don't have long-term data that comes up after it gets used. So yes, I do use Dayvigo in patients who have failed other treatments, but it's certainly not my first, second, third, or fourth line. But I do use it, and I've had pretty good success with it. But I'm just waiting for what happens over the next 5 years and the post-marketing studies come out.
Oh, and another, medication relation question, or related question. Are you recommending LD naltrexone for long COVID CSS symptoms?
Absolutely. And so, in fact, we have a lot of patients who have been turned off to medications because of their sensitivities and their side effect profile. And so what I do, my strategy is, I think everybody should try two things. One of them is PEA, the supplement, and low dose naltrexone. And so what I say is that, I know you're not really interested in prescription medication, but I want you to go on Google Scholar. And I want you to do a search for low dose naltrexone. I call this the medication for people who don't like medication. And the reason I call it this is, number one, the dose is minuscule. We start off at 1/100th of a tablet. And number two, at those doses, we almost have no side effects. And number three, patients like the way that it works. It doesn't mask anything. It actually reduces the inflammation, the neuroinflammation, and has a broad effect on your symptoms. On average, I expect around 20% improvement. Some patients more, some patients less. So that's my spiel, because often when patients say, no, I'm not interested in medication, we just kind of stop there rather than exploring what other things they might be interested in.
Okay, and there's a couple of questions here that are about exercise. So someone asks, are there exercise and activity limitations for people with long COVID? And similarly, someone asks that they have some concerns about recommending rest as a treatment, especially with someone with chronic pain. How long is this recommendation advised?
So I can tell you that if you get these patients to push through their symptoms, they will have post-exertional malaise and worsening of symptoms. People quote the PACE study that came out that tried to say that if you slowly increase the activity level, these patients will get better. That paper has been retracted. There has been at least 10 editorials to talk about how much harm was caused to patients. When I did a presentation to rheumatologists, not a single one knew about the association of fibromyalgia with chronic fatigue syndrome. And so when patients didn't take their exercise recommendations, they said patient's non-adherent rather than the patient saying, I can't do this. So my recommendation is if you have fibromyalgia or long COVID without post-exertional malaise, push through symptoms. Push through symptoms, exercise, because what's happening is the pain that you feel is good pain. It's kind of like the pain when I haven't worked in the garden for a year and I work out the first time. It tells me I'm using my muscles. You're not damaging your muscles. You're not damaging anything. This will help you. But if you have post-exertional malaise, it's a game changer. And so you will kill any possibility of remission or partial remission by having patients push through their symptoms. Some patients are going to be bedbound for a year or more with aggressive rest therapy. The good news is that the vast majority of patients, only 1 or 2, have persisted in requiring or not being able to do much more than 5 or 10 minutes of activity. But we kind of forget that the range for these conditions in terms of severity is huge. Some people are essentially bedbound. 25% of patients with these conditions are housebound at some point. So it's not the pain that's the restrictor, it's the post-exertional malaise. Definitely work through pain, but do not work through post-exertional malaise. In terms of activity, I just had a physiotherapist. I do special lectures every week or 2 for my patients. And you can have a look at my website if you have any patients who think might be interested. But we had physiotherapists. And the point that we made was that you shouldn't make a distinction between activity and exercise. That we would much prefer you walk through the grocery store and pick up cans and put them in your cart rather than go for a walk and do light weights at the gym. And so we say that exercise is a luxury for those patients who can do all of their activities of daily living without causing post-exertional malaise. Then you have the luxury of exercise. Otherwise, you should be doing functional activities with and consider that exercise. The second reason you should exercise, because I always tell patients that you have limited activity tolerance, a limited energy envelope, and it's used for 2 things, self-care and joy. If joy happens to be going to the gym and there's a trade-off, then you might want to do it for the joy part. But in terms of doing it to improve your health, you're much better off with functional activities.
Yeah, and I think that speaks to a couple of the other questions. People asking about, non-pharmacological strategies for managing these conditions, and so it's sounding like, where exercise and movement may not be the way, that there are definitely many other things that people can do. Can you maybe speak to, just some other recommendations that you give?
Yeah, because I have a lot of, one of the big things is nutrition and diet. There are patients who on a low inflammatory diet have as much as a 40 or 50% reduction in pain. In fact, I've had some patients who no longer fulfill criteria for fibromyalgia after going on a low inflammatory diet. I think there are a number of supplements that can help. Stretching is good as long as you're not hypermobile, because remember that hypermobile patients also get these conditions. So in the same way as exercise is good unless you have post-exertional malaise, stretching is good unless you have hypermobile Ehlers-Danlos. So working with a naturopath, working with an OT on energy conservation, working with a PT on using your heart rate as an estimate for your VO2 max and staying within your energy envelope. I do cognitive behavior therapy with my patients. I have an 18-week group. So I think that it's really multimodal for these patients. It's pretty much what they do at Pain BC and what they recommend. It's all that good stuff that I would say that there's a huge part of my practice that is non-pharmacological and only a tiny, tiny, tiny little sliver that's actually internal medicine medication. Most of it is other stuff.
Great. Okay. Just looking at, so a couple people asking about referrals. So like someone says, I have a 17-year-old patient with POTS and nausea/vomiting on top of pre-existing gut symptoms, ASD, and some psychiatric symptoms, including depression, anxiety, eating disorder, self-harm, and PTSD. Where do I begin to help them, or who can I refer them to? I think they're on Vancouver Island. And then someone else asks, what is the best way for allied health professionals to help patients connect with specialists, places, information to get a diagnosis for these types of conditions?
So number one, I don't have any advice for anybody who's under 18 or 19 because I'm not a pediatrician. But anybody who's 19 and over, I'm happy to see in my practice. There's also the Complex Chronic Diseases Program at BC Women's Hospital that see patients with chronic fatigue syndrome and fibromyalgia and chronic Lyme disease. Unfortunately, there are not a lot of doctors in the province who see patients with these conditions. Yeah.
Okay. I don't know if this may be related. What are your first, second, third choices for sleep? It seems as if many patients still have issues with sleep despite using sleep medication.
Yeah. So the sleep medications can help a bit with sleep, but they actually don't improve the underlying sleep architecture. The only medication that's really been shown to improve sleep architecture is the date rape drug, which is only available if you have training as a sleep doctor. And so we're really limited in what we can do for sleep. And most patients are left with unrefreshing sleep even after we improve sleep initiation and sleep maintenance. So that's not, so unfortunately, we can't target the unrefreshing sleep part of it. We can help them get deeper sleep a little bit. We try and choose medications that don't disrupt sleep architecture, so don't make it worse. So the benzos and some of the non-benzos like zopiclone, so avoid those. But the focus then becomes sleep initiation and sleep maintenance. And also another thing that can make a big difference is using small dose of antihypertensive medication for the people who have PTSD. So tiny, tiny little dose of clonidine is about 90% effective in nightmares.
Okay, and another question about just in all the studies that you reviewed, do studies profile or include folks who are formerly athletic or healthy, active, who now find themselves, quote, helplessly hobbled? I get the pre-existing vulnerabilities, but it seems that post-COVID symptoms seemingly attack people randomly.
Oh yeah, but remember that these are invisible conditions. So the people that you think that are being attacked randomly might have underlying interstitial cystitis, IBS, PTSD, hence the medical gaslighting. And so it does affect people randomly based on genetics, adverse childhood experiences, and pre-existing central sensitivity syndromes. So I don't think it's completely random. And if you came to one of my groups, the vast majority were high performing professional people, type A's. Like there weren't people who were deconditioned beforehand. I saw a woman just before this who said, I felt like I was chopped at the knees. Here I was managing, working out, I was managing a career, family, and now I can barely wash my hair and take a shower every day. And so these are high functioning people who run marathons, that those things don't protect you against getting these conditions.
I think that's a really important point. Yeah. Someone asks, as an allied health professional, my long haul COVID patients exhibited symptoms akin to Guillain-Barré syndrome / phrenic NN damage. Are we also considering the neuroinvasiveness of this disease?
Yeah, and that's why you have to be careful, because some people will have actual tissue damage of the nervous system, and these are better described as post-acute sequelae of COVID with tissue damage than long COVID. But like I said, the language is being used very loosely. And so yes, because Guillain-Barré can be triggered by any virus. And so it's not really long COVID, it's Guillain-Barré triggered by COVID. Just like we don't need a new name for a lot of these conditions. But yes, in the beginning, when I said it's either tissue damage, unexplained symptoms, or psychiatric, I forgot to say that often it's all three. And so patients can develop anosmia, as well as chronic fatigue syndrome, as well as new PTSD and anxiety. So they're not mutually exclusive. Important point. Thank you.
A question about some new technology. Do you think that AI might offer an effective tool for early diagnosis of such symptoms or syndrome? Sorry. Are you aware of any research happening on streamlining diagnostic processes for ME/CFS and CSS syndromes?
Well, I don't think that we need AI. This is such a simple diagnosis. The problem is the way that our medical system is organized, right? Because if you're a primary care physician, you don't allow multiple symptoms because that would be impractical in your practice, but most patients have 20 or more symptoms. And if you're a specialist, you're looking through a tunnel and you're not interested in the symptoms that are outside your wheelhouse. And so we have a system set up not to pick this up. But once you have the key symptoms, fatigue, sleep disturbance, brain fog, unexplained symptoms, and pain, it's a very, very easy diagnosis. And I also want to remind you that it is not a diagnosis of exclusion. You do not need to do a lot of testing. In fact, you go to the BC Women's website, it's just a handful of lab work to make sure you're not missing anemia, HIV, liver disease, kidney disease, some very, very basic, that these are not diagnoses of exclusion. CRP, no ANA, because ANA is false positive, but these are, I don't think we need AI for any of this.
All right, I think we'll do 2 more questions. What do you think would be a more effective approach to communicating with clinicians who say, quote, I don't know how to help you? After seeing negative EMG studies, MRI, etc. Word of caution, these doctors may be authoritative in treating patients with not as much empathy and/or compassion in their tone and verbiage of communication. So what would be a more effective approach?
So to be perfectly honest, and I'm going to give you my real answer, is that what I tell my patients is to treat doctors like technicians. So that when you're going to the neurologist, don't expect them to tell you why you're having symptoms. Expect them to tell you that there's nothing happening that's in their wheelhouse, so that you don't need to be worried that there's an obvious thing being missed. And so if you expect to be reassured, if you expect to have an explanation, they don't have the expertise. And like the person asking the question said, they may not be the right personality to give you, it's like an old saying, don't go to the hardware store for milk, you'll be disappointed. And so in the same way they use the test, if you're going to see the GI doctor, they may not be able to explain your symptoms, but they may be able to tell you you don't have Crohn's disease, you don't have cancer, you don't have, and so use the specialists that way. And then hopefully you'll find a physician who will be your quarterback and help coordinate all of this.
And lastly, any thoughts about using infrared light to manage pain from fibro, long COVID, et cetera?
Yeah, it works extremely well. There's not a lot of studies out there, but for a lot of patients, it works extremely well. Keep in mind that for a lot of patients, it makes pain worse. And those who have significant dysautonomia associated with this, or problems with temperature regulation, problems, so those patients actually feel worse. And so I can tell you which of those patients are in my practice, because when we had the heat wave, these are all the people who are doing worse, as opposed to during the heat wave, all the people are saying, oh, my pain is much better. And so keep in mind that, yes, it can be really helpful but there is a subgroup of patients who won't tolerate it because of dysautonomia.
Gotcha. Okay, so approach with caution. All right, well, thank you everyone so much for your excellent questions. I'm sorry we couldn't get to all of them, but we covered quite a few in that time span. The website for Dr. Arseneau is on the screen there, so I encourage you to go check it out and to learn more. I will just paste the link for our survey in the chat, and I think it'll also pop up on your screen when you leave here today. We'd love it if you could complete the survey and let us know what you thought of today's presentation. You can also suggest topics for future webinars as well, and so we hope you do, because we find that very helpful. Yes, and thank you again for spending your lunch hour with us. I hope you learned something. I certainly did. I was taking notes frantically as you were talking. Yeah, I hope we will see you for the next webinar, which, as I said, is going to be on October 19th. Until then, take care and have a wonderful rest of your Tuesday.